Good evening, Dr. Sureka.
Good evening, Dr. Sushila. How are you? Thank you for accepting our invitation at short notice.
Yeah, it's my pleasure, madam.
Yeah, thank you.
Being after you've taken over as clinical research, I think even Vijayawada Society will get good opportunity to participate.
Yeah, definitely. Thank you so much. And we are glad that we are able to do quickly our programs immediately after taking over. So this is Shanta ma'am's program. She has curated it so well.
Yeah, so well, yeah.
It's definitely a lot of efforts.
Yeah. So even like it is very close to our Obgyns to say we have done almost like 39 sessions.
Yeah, you have done a lot of work. I mean, it's too. We are trying to, but not as many because
almost 10 schools are in pipeline to go ahead.
That's really great work, and you deserve the Dheera award more than anybody else, I think.
Thank you.
I'll just ask my people to join so that we can start on time, because it's almost 8 topics.
Yeah.
8 topics, and even if we give 15 minutes to each, it will be like 2 hours.
2 hours, yeah.
Yeah. So, and the length of, sometimes it is difficult to really keep the attention of people for 2 hours.
Very difficult. 2 hours, like attention span, I don't think.
Yeah. That's why I think the presenters can be a little bit brief, and we can allow the comments and discussions.
Interactive session, I think.
Yeah.
And the topic you are taking, the last topic is like
the most important one.
Important.
The last topic is the most important one. I'll just give a call to Pratibha.
Yeah, okay, ma'am.
I already called, madam. Madam said that she'll log in now.
Okay, thank you. Thank you, Shriman. No. Thank you so much. Nidhi, Neema man is joining. Have you called her?
Yes, ma'am. I called her twice. She's not picking up.
And no worries. We'll start. Whenever she joins, we'll take her comments.
Okay, ma'am.
Hello.
Hello. Welcome, and thank you so much for accepting my invitation at such a short notice. I'm so thankful, Pratibha, being a Sunday. Thank you so much. I was just trying to call people, so that if they join quickly, we are able to start.
Good evening, Dr. Pratibha.
Good evening. Actually.
Oh, are you not well?
Yeah.
अरे आपकी आवाज तो पूरी गई है.
But today I'm better, so I thought I'll go and do.
Yeah, I think you have a bad throat, madam.
Bad throat. For last 3 days, I'm running temperature actually.
Oh.
So I'm so sorry.
No, it's okay.
You can have some tea, warm tea. You must be doing all that.
I'm taking everything.
I just talking with Sushila that the module is really, very comprehensive and compact.
Yes, very good.
Yeah, really. lot of efforts.
Lot
Yeah.
of efforts. Yeah.
So, really going through our subject OBG and all this thing is like, that is okay, but going away from our routine and then
It is
taking
very
up this
difficult.
topic,
Yeah,
very
yeah.
difficult. Yeah.
Yeah, very difficult. Previous module was also very good. Which that
Yeah, school education.
School education, that was also good.
And then after the program, usually like wherever we'll have done the program, the interactive session was going on actually more than half an hour to say.
Yeah, yeah.
Even the students, like they were so interested and then they were raising so many questions.
So we have more than 50 registrations, but it is taking time to, people are taking time to join.
Yeah.
Anyways, we will start, because it is huge. So just immediately 5:30 we'll start.
Sure, sure.
And Nidhi, I can't see Nidhi. Nidhi is there?
Yes, ma'am. I'm
Yeah.
there.
Have you called the faculty?
Yes, ma'am. They're
Yeah.
joining, ma'am. Actually, there is some problem with the link people are facing. They're not able to join at first. So we're just resolving
But
that.
you joined, no?
Yes, ma'am. We have to join via the mail. The mail that the Zoom has sent us. Everybody has got their own link to join.
Yeah, yeah.
So there's some
So
problem.
this link which I have posted, you are not able to join?
No, ma'am. Not from that one.
Okay, individual posts.
Yes, ma'am.
Yeah, they have to do the pre-test actually. Yeah, pre-test. After that only they get the individual link.
Yes.
Okay, let me post the Bhageshri. Can you post that link? Okay, that means okay. Okay, we do have. So we can wait for a few more minutes and then we will start. So let me take the opportunity to welcome everybody to this very important session of Dheera, Say No to Violence Against Women, which is the flagship program of FOXY under the program director, Dr. Shanta Kumari ma'am, who is the president of FOXY 2021-2022. And we have our head of department from the Department of OBGY, Jawaharlal Nehru Medical College, Dr. Nima Acharya, and I would first invite her for the welcome address.
It gives me immense pleasure to welcome you all for today's, the CME on Dheera concept. And we all know that how FOXY is active in women empowerment, and we all are united for this cause of violence against women. So we are very proud that we have Dr. Surekha Taide with us in our department, who runs the flagship of our society, that is the DSOGA society, and we are always there with her. In fact, she leads us in all these activities, being a president presently. And without wasting much time, I welcome you all for today's CME, and I hand over to Surekha Taide ma'am. Once again,
thank you so very much, Dr. Nima, for all the support and encouragement for all the activities and the collaborations with the department, which we keep on having for each and every activity of the SOJ. So we are very, very thankful for all the support and for the participants who have joined today. And I would like to just introduce that Dheera is the flagship program of Dr. Shanta Kumari, and a lot of efforts have been put by Dr. Kiran Mai and Dr. Vindhya to prepare the modules. So first of all, the credits and the gratitude to all three of them for the wonderful efforts they have taken. And of course, I would like to thank Dr. Sushila and Dr. Pratibha Singh for accepting our invitation to be faculty for today's event. And I would just like to briefly first of all, introduce all our speakers. So we have 3 speakers. Myself, I don't think I need to introduce myself in front of my own audience. So, and then we have Dr. Pratibha Singh, who is a really dynamic person, presently the chairperson of International Academic Exchange Committee of FOXY, and she has been doing a lot of work for Dheera. She's a consultant laparoscopic gynecologist, IVF specialist, but she's doing a lot of social events and work also. National coordinator, she was previously for the AEC committee, and she's presently the chairperson. She has been the president of the Bhagalpur Society, Bhagalpur OBG Society and Menopause Society, both. And as you can see, lots of presentation, papers, and awards she has. As you can see, she is credited with a lot of academic. So welcome, welcome Dr. Pratibha. And we have Dr. Sushila, who is from the Vijayawada Society, and I have a lot of good association with Dr. Sushila. She is consultant OBGYN practicing at the Lata Super Speciality at Mangalgiri, and she's the president of the Vijayawada OBG Society presently, also the secretary of the Vijayawada Menopause Society, member of the MTP committee of FOXY, secretary of the first APCOG 2015, and you are South Zone, you are FOXY in 2018. She's a certified trainer for contraception, and she's a Dheera and RAC master trainer. Various books and chapters to her credit. So thank you both of you for joining us here, and we would immediately start with the first topic which I'll be taking, and that is on introducing what is violence against women and the concept as such, so that we are able to understand. We are having this pre-registration, which is important for this event, and after that, let me remind all of those who have joined this event that at the end of the program, we'll be having a feedback and post test, after which you will be receiving the certificate. So do not forget to do the feedback and the post test for this program. So let us go ahead and listen to the overview of violence against women. These are the contributors, and the gratitude to the contributors for this module. Gender-based violence actually what forms of gender-based violence are experienced as women and girls? Where can women and girls experience this violence, and which age group may experience? So I would like the participants to just put their comments in the chat box. What do you think about gender-based violence, and where do you think women and girls can experience this gender-based violence? So keep on interacting in the chat box, please. So violence against women is any act of gender-based violence. It can be physical, it can be psychosexual, psychological, and sexual also. So it could be physically harming the woman, or it could be just a coercion, deprivation of liberty. All these also are acts of violence, and it could be sometimes condoned by the state. I don't think in India it is condoned by the state, but there are some geographical regions where violence against women is considered a normal thing, normative thing, and not much is done for that. So physical violence, as you can see on the kicking, biting, clapping, beating, strangling, and psychological violence, where the woman is belittled, economic restrictions, threats, other forms of controlling behaviors. All these are also psychological violence. And of course, sexual violence. We will be having more on this by Dr. Pratibha. So sexual violence, we do know it's a violence against women. And intentionally inflicting injuries, which are often disguised as accidents. This we also come across in our OBGYN practice. So 30% globally have experienced physical and sexual violence by their partner, though this much we do not have the reporting of, 40% are experiencing the violence, only 7% are reported to a formal source. And basically, if you look at the data, very less number of incidents are reported, and that's why the interventions are also very less. And this is the cycle of abuse, as you can see, starts from infancy, from the sex-selective abortions, female infanticide, again, child marriages, female genital mutilation. Then we are also know about trafficking, honor killing, marital rape, murders, all these we know. And of course, forced pregnancies, even forced MPs, acid throwing, economically coercing sex, incest, and sexual abuse in the workplace. These are the type of the violence which we can see. Now, health impacts are huge on the individual as well as on the society. Acute impacts on physically and chronic one, like there can be injury, shock, disease, infection, regressive behaviors, anorexia, chronic physical effects like a disability, chronic pain, GI disorder, eating disorders, sleep disorders. And of course, if it is in the pregnancy, then there can be miscarriages, unsafe abortions, sexually transmitted diseases, pregnancy complication. These are all the impacts which we can have on the individual. Now, effects beyond the individual, of course, the effect will also be on the family and also in the community and the society, because the woman is considered the pillar of the family. If she is being treated in this way, there definitely there will be effect on the family. There will be, if the child is experiencing the abuse, there will be the higher rates of infant mortality, behavior problems, poor school performance. Effects on family, definitely the relationships will be fractured, house will be unstable. And if and concurring violence, so if somebody is suffering the violence, then concurring that person may inflict violence on another person in the family, that we have seen so many times. And of course, the cost of services to these victims and families is quite high. Loss of education, then of course higher crime rates, burden on the justice sector. All these are beyond the individual survivor you will find. And HIV and violence also is related, because there could be a direct transmission through sexual violent behavior, and there could be indirect transmission through sexual risk-taking behavior. like, having multiple partners, non-primary partners. And of course, if there is an inability to negotiate the condom use, the woman may find it that in case of intimate partner violence, or where she is not able to negotiate the use of condom in her relations, even in a marital relationship, there could be the transmission of HIV and AIDS. So this is overall. I'm not going to go into minor detail, but of course, the physical trauma, psychological trauma, and fear and control. These are the various ways in which the violence can be occurring in women. And there are certain myths and facts which have to be really, we need to clear these myths so that we understand the nitty-gritties of violence against women. Now, first statement is intimate partner violence is more prevalent among poor women and girls. What do the participants think? Yes or no? You can write in the chat box. I may not be able to see the chat box, but I will read later on. But we do know that it is a myth. Studies show that gender-based violence not only occurs in the amongst the poor classes, but it also occurs in the higher socioeconomic groups, educated women, and it may even occur amongst your own peers, colleagues, and friends. You may not know that the person is suffering from violence and she needs your help. Another myth is majority of sexual violence against women is perpetrated by strangers. And that is totally false. Actually, most of the time, the perpetrators are those they trust and love. Globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. So person whom you know is the one who most of the time commits the violence. So another myth is that it is safer for a woman to leave a relationship with an abuser than to stay. In fact, it's a myth. Violence often continues and even may increase once the woman leaves her partner. In fact, a woman's risk of being murdered is greatest immediately after the separation. So, gender-based violence is a serious human rights, health, and development issue impacting the survivors, their families, and the health and development of the entire communities. So we'll be going ahead with the module, but let me again remind you that after the registration, there is a pre-test, and at the end of the program, there will be a post-test and feedback. So keep on posting your questions in the chat box, and we will have some discussion after maybe 2 of the presentations. So we can have your. So Nima madam, are you not able to hear? Yeah, please go ahead. Please go ahead with the next topic, how to approach a woman facing violence. Dr. Pratibha, you'll be talking on that.
Hello, can you hear me?
Yeah, we can hear.
Can you see my slides?
Yes. Please go ahead.
Yeah. So, good evening, everyone. And first of all, I would like to thank Dr. Sureka Taide for giving me this opportunity. And actually, this is the program which is a brainchild of our past president, Dr. Shanta Kumari. And it is really doing very well. So we all must know how to approach a woman facing violence. And before that, I just want to tell you that I'm really sorry. Actually, I was I was not well and I was having fever and I had a very bad throat. So please just excuse me of my bad voice and sometimes I may cough also. So please excuse me. So now how to approach a woman facing violence. What we have just listened just now, the overview of violence against women, we have just seen that how 40% females are suffering this violence and they are having this violence, but only 7% we are going to recognize them. And most of the time, these survivors, they do not seek help. So there are so many reasons, many obvious reasons, like they are in fear of shame and stigma because of this incidents. They feel that what everybody will say. Then they also have a fear of no confidentiality. They feel that if this incident everybody will come to know, then they will be saying that, okay, this girl is dead, this female, this thing has happened with her. So this is very common. Also, victim blaming attitude of the provider, inappropriate service or services that are not useful for the survivors, and perceived impunity of the perpetrator. Now, if you can also think of other reasons also, please put it in the chat box. Can you hear me, Dr. Surekha? Hello?
Yes.
Yeah,
Yes.
you're audible.
Okay. So now, how are you going to help such survivors? And who can play the role to help these survivors? First and foremost, your beloved family members and your friends. Then comes the community, and then the service healthcare providers like we. So role of family, friends, and community is very important, because recovery from the violence depends upon extent of support received from their loved ones. And even healthcare professionals, they should engage the family and should discuss the way of proper survivor being, how the survivors can have the well-being. Then the person who is giving this care, they should not always think that these survivors are responsible for such type of assault. You should not blame them. That is very, very important. Otherwise, they will not come out from their trauma. Also, you should not reiterate them, because perpetrator who has misused his position, that is why he has done such type of crime. So it is not the fault of the survivor. What happens sometimes, child sex abuse, mostly the parents, they experience anger, confusion, and guilt. And they start blaming themselves that it was because of them, it has happened like this. So that is also not good. It should not be done like that. Then the role of healthcare provider is very important, because violence is an underlying cause of any type of injury which can occur to that survivor and can cause ill health. So most of the time, these women have to seek help from we doctors and the healthcare services. So they often feel that we are the most trusted person, and we sometimes become the role models also for them. So we have to be very, very compassionate and very, very considerate about these survivors. Another role of healthcare provider is creating an enabling atmosphere and establishing trust. And how can you do that? Speak to the survivor in a private place, or you should have a proper when such type of female approaches you, you should take proper attention to such females. Recognize her courage in reaching you, as they have overcome several barriers. And you must also recognize the dilemma faced by the survivors in reporting violence. Sometimes they don't want to speak out about the incidents. So do not label them as non-reporting to police as a false case. And very importantly, the treatment should not be compromised. Whether they tell you or if they don't tell you, if they have come to you, if you feel that she is in need for some immediate medical help, you must provide that. Then in between, you can also inform the survivor about the available resources, legal rights, so that they can take an informed decision. Another role of healthcare provider is facilitation and the demystification of the medical procedures. Because we are doctors, so our first duty is to treat the patient. So prepare the survivor for internal examination, and it should not be the normal way, the way we are looking to other patients. You have to explain to her about all the various stages which you are going to examine her, what all you are going to do with her. What you must tell her that maybe you will be needing an X-ray, ultrasound, or some other investigations. So you must tell her what all way you are going to examine her, or what all treatment you are going to give her, so that she feels comfortable. Then another issue to address is about her emotional well-being, because these survivors may present varied emotions. So encourage the survivors to express her feelings, encourage survivors to seek crisis counseling, assess for suicidal tendencies, because many times they feel that they want to end their life. So you must assess that. And if you feel that she is in that position, then you should make a safety assessment and safety plans. And you must involve the family members, especially those who are their beloved ones, friends, so that it will help in the healing process. These are the few statements with which you can console these females, like take your time, share only when you would like to share. I can imagine that must have been really hard for you. It takes tremendous amount of strength to share what has happened with you. So this all thing, so she feels that you are really concerned about you. Then how do you think we can help you? Or you are not alone, we are with you. Whenever, whatever help you want, whenever you want, we are with you. So these are the few statements which can console her and with which she can come out with the problem which she has. Now the practical approach is by making her sit in a proper position, proper posture, leaning forward, eye contact, and in a relaxed environment. So that is very important. And supporting gender-based violence survivor using this LIVES approach, that is listen, inquire, validate, enhance safety, and support. So how are you going to listen to such survivors? With your eyes, giving her your undivided attention. With ears, you can truly, by hearing what she is talking, then with heart, with caring, and with the respect you should give. You can use verbal or non-verbal means to show support and communicate understanding. You can also ask questions which can be open-ended or focused or closed ones. You should have a good body language. When you are sitting in front of her and she's talking to you, your posture should be good. You should be listening. You should have an eye contact, and it should not be like you are talking to somebody else and in between you are listening. So it should not be like that. And always, always avoid leading questions or compounded questions. So what are the do's and don'ts of listen? Be patient and calm. Let the client tell you her story at their own pace. Do not pressurize her to tell a story. Let her know you are listening through her verbal or non-verbal cues, like you can nod your head, or you can say yes, okay, or you can maintain a gentle and appropriate eye contact. Do not look at your watch or speak too rapidly, or you start looking at your telephone, or you start looking at the computer, or you start writing something, or somebody is entering in the room and you're talking to them. So it should not be like that. You should pay full attention to that leading. Acknowledge her, what she's feeling. Then don't judge what she has or she has not done, or and don't say that you should not be feeling this way, or you should not say that you are really lucky you survived. Give her the opportunity to say, how can I help you? Or would you like to tell me more? So these are few questions, few ways to listen to such person. Don't assume that you know what is the best for her, and don't interrupt. Wait until she finishes what she's talking, and then only you should start asking questions. Allow for silence, give her some time to think. Do not try to finish her thoughts for her. Stay focused on her experience and on offering support. Do not tell her that, oh, same way somebody else also had same type of problem, or even I had some problem, so I did like this. So you should not be telling all those things. You must listen her experience, what she has to offer to you. Acknowledge what she wants and respect her wishes. What she wants, you must always respect her wishes, irrespective of what you think about it. Don't think and act as if you must be the one who can solve her problem. Now, second is inquire about needs and concern, and how can you act in that? Phrase your questions and invitation to speak the way so that she becomes open. You have to become compassionate. Then you must ask open-ended questions instead of yes or no questions. Check your understanding by restating what she or he has to say. Reflect back to the client the feeling that they express, explore as needed. Ask for clarification if you don't understand what she has told you. Help her to identify and express her needs and concern. And finally, what she has told you, you must sum up what she has expressed so that she will also understand that you have understood what she wanted to tell you. You can also inquire, like you can say such type of sentences. What would you like to talk about? How do you feel about that? You mentioned that you feel very frustrated. It sounds as if you are feeling angry about that. Could you tell me more about that? Can you explain that again, please? Is there anything that you need or are concerned about? You seems to be saying that. So this way you can be in the conversation with her. Now, third point is the validate. So validate does not mean to try and verify the survivor's story. For example, through interviewing the alleged perpetrator or witnesses. This is not safe, appropriate, ethical, or recommended. On the contrary, you should show them you understand and believe what she is saying. You can console her that it is not your fault, you are not to blame. You did the most important thing you could do at that moment, and luckily you survived. If you want some help, help is available. You can tell about the way you can help her. No one deserves to be hit by their partner. You must say that this is the wrong thing which has happened with you. You are not alone. Unfortunately, many others also have such type of problems, but they don't speak out. You are speaking. That is why we are helping you. So this way you can validate. What happens has no justification or excuses. Your life, your health, you are of value. Then everybody deserves to feel safe at home. I am worried that this may be affecting your health and it is okay to talk. So this way you can validate. Now you must also differentiate between empathy versus sympathy and for creating boundaries. Now what is sympathy? It is identifying with the survivor's experience through your own shoes. That is, it is personal emotional identification with the survivor's experience implies that the service provider feels sorry for the survivors. जैसे हम लोग कहते हैं ना, अरे बेचारी क्या इसके साथ बहुत बुरा हुआ बेचारी. So this is sympathy. Whereas empathy, it is attempt to put oneself in the survivor's shoes. It implies intellectual, personal understanding and realistic professional distance. It is professional distance. It involves compassion and objectivity and leaves room for empowerment for the survivors. So empathy is better than sympathy. Ignoring violence can do more harm. So we healthcare provider behavior is very important. We must not blame or disrespect women or girls because the possible consequences will inflict additional emotional disturbance, distance and trauma. If you don't recognize gender-based violence behind chronic or recurring conditions, then women receive inappropriate or inadequate medical care. If you fail to provide post-rape care or address gender-based violence in family planning, STI and HIV care, then it may result into unwanted pregnancies, STIs, HIVs, abortions, and more violence. If you breach the privacy or confidentiality, that is also very important. You have listened to her story and you have started talking to everyone, then the partner or the family members may become violent after overhearing in such information. Ignore signs of fear or emotional distress. Then in such case, women may later get injured, killed, or may sometimes commit suicide also because they feel that nobody is there for her. So this is a Salvadoran woman who has given this statement that the doctor helped me feel better by saying that I don't deserve this treatment. And he helped me to make a plan to leave the house the next time my husband becomes violent. So women are not responsible for men's violence. You may be his excuse, but you are never the reason for his violence. These are the 4 ways you can help such women. And this is through her health, proper health, psychological support, legal justice or security. Like if a survivor reach out to you, either to the family or to the community or to the healthcare providers, then if she is injured, then she should be immediately taken to the for the medical examination and to the
for the medical
and,
examination and to the
and from there you should give a psychological support. Then medical follow-up should be given, protection and investigation, justice and legal aid should be given to such females. So warm referral practice help women reach further care. So thank you so much. Now, again, I will request you already have done your registration and pre-test. You must complete your post-test and feedback form so that the certificate of participation will be awarded to you. Thank you so much.
Thank you so very much, Dr. Pratibha, for that comprehensive talk. And we have a lot of faculty who have joined here from Jawaharlal Nehru Medical College. We have Dr. Pramita Muntode. I welcome you, ma'am. We also have Dr. Deepika Devani, Shikha, and Toshniwal. We have Dr. Milind Jagdale. So we also have a lot of members of the Devli Samgi Uji Society. So I am giving a warm welcome to all of you for joining this program. So with that, we go ahead for the next topic. And the next topic is effect of violence against women and the newborn. And I would like the participant to keep on posting any questions if they have in the chat box so that we can answer them. So initially we will be going quickly through the presentation, and then at the end probably we'll have some time to give to the discussions. So in this talk, I'm going to talk about more clinical aspects, like when you see patients in your OPD, you know what to do, how to diagnose, what are the common clinical presentation. I'm sure you must have seen some patients in the OPD, victims of violence and abuse, and you must be able to recollect a scene or two of what the patients you have seen in the OPD. So this is one of the women who was interviewed in Peru when she was pregnant and she was suffering from violence. She said, he hit me in the belly and made me miscarry 2 babies. I went to the hospital with heavy bleeding and they cleaned me up. So we do see such kind of patients in our setup too, and we are looking at complications like PROM, prolonged and sorry, I think I'm not able to see. Okay, this is the case study of a primary gravida who came with PROM and prolonged and obstructed labor. She presented with the rupture uterus and shock, and she actually succumbed to this event. This patient, actually, the history revealed later that there was history of brutal kicking on the abdomen by the husband, and she was pushed violently and she fell on the sharp edge. And actually, this was not, death was related to violence, and it is masked by the other pregnancy-related disorder. So history is very important. You know, this is another patient who was a 3rd gravida, para 2, living 2 and 28 weaker, and she had a previous 2 LSs. She reported to us with shock, placenta accreta, hysterectomy was done, 10 blood transfusion, bladder was involved, and later on, we came to know what precipitated the bleeding was the husband kicking on the abdomen. So important is again that you are able to, if you are able to, screen women for these things, then only you are able to pick up. Otherwise, you will think that this is all related to pregnancy. So if you suspect, probably you should be going detailed into the history. Another case study, a woman with severe preeclampsia came unconscious. She was having CVA and leading to maternal mortality. So initially it was thought that this death is due to eclampsia. However, this death was not due to eclampsia, but it was due to the hemorrhage. This was because of in the postmortem that we could find there was a fractured skull and cerebral hemorrhage, and this death was directly due to violence caused by the husband. So again, hidden violence is masquerading as the maternal disorder, and so you have to be careful about inquiring into the history of patient. Another case study, third gravida, para 2 life 2 with previous to LSCS full term. The rod was implanted due to the fractured femur and the fracture of the hip joint. This lady collapsed in front of a hotel. She was brought in the hospital in 108 ambulance in active labor, having severe hypertension. Emergency LSCS was done for this patient. No accompanying person was there. The consent was given by the RMO of the hospital. And as you can see here, the signs of trauma on leg and on hip. She was pushed from the second floor, and she was abandoned by the husband also. So this is how the trauma, on the patient, and you really have to suspect if this kind of trauma is seen in a lady, especially who is a pregnant lady. Third gravida, again, para 2, no live children, previous to LSCS, severe anemia, 36 weaker. Both times in her pregnancy, she had history of physical violence, kicking in the abdomen brutally by the husband, loss of fetal movements after that. Only in the third pregnancy, when her parents brought her home, she was well taken care of. She was transfused blood and she could have a live baby. So you can see that violence in pregnancy is also having huge effect on the mother as well as the baby. Here is a case study 6, sixth gravida, 2 live babies, but 3 abortions, 2 previous cesarean section, and these are the 3 induced abortion. She came in acute hemorrhage, shock, sepsis with an incomplete abortion. And this severe form of physical, emotional, and these we all must recognize these are the forced abortions. Probably she had 2 female children and they wanted a male child. So there is a direct history of violence, and this is brought about only after screening by history and clinical examination. This lady also had to receive 4 transfusion because of the acute hemorrhage. This you can see here, the trauma, so severe kind of trauma is here in this patient, as you can see, and stab injury. This was caused by the husband. He was inebriated, lacerations on the face. You can see perforated uterus here. The fetal demise also occurred, and there had to be a laparotomy for repairing this rent. So huge kind of problems the patient can have, especially in a pregnant woman. So what is the gynecologist specialist stakeholder in the women's health? She is in the unique position. She can assess and provide support for women who experience this violence, especially because we have a different kind of nature of patient-physician relationship. Many opportunities are there for intervention that occur during the course of adolescence, pregnancy, even during family planning, counseling sessions, annual examinations, and other visits of the woman. So important question is how to elicit the history. We cannot ask direct questions. Specifically, we have to be very careful if the husband or the partner is accompanying. So these questions could be like, is everything all right at home? Are you getting on with your partner? These could be the questions. Certain screening tools are available, the abuse assessment system. There's a heart scream, humiliation, afraid, rape, kick screen, hit scream, hurt, insult, threat scream, screen. And these are the other assessment tools which can be used. The WHO actually recommends that all health professionals should be trained in the first line response to family violence. The steps are listen, believe, inquire about the needs, validate the person's experience, as Dr. Pratibha has very rightly said in her presentation, enhance safety, and offer ongoing support. Universal screening or routine inquiry is actually not recommended. However, WHO has guidelines and identifies antenatal care as a setting where routine inquiry could be implemented if providers are well trained on a first line response and minimum requirements are met. So if you are well trained, you will understand the opportunities where you can ask. And first and foremost, it is important to ensure safety. Look at the condition, if the partner is present or not. You should identify evidence on benefits as well as potential harm of your inquiry, and then only you could inquire about intimate partner violence. And you always should ensure the safety of the woman who has come to you in the OPD. So that was about how you should be dealing with the patient who comes in to you in the OPD. And I can open up the forum for a few questions if there are any, and then maybe we could go ahead with the next presentation. So anybody who would like to pose any questions are welcome. They can unmute themselves and ask questions, or they can put in the chat box. If not, we go ahead with our next presentation, which is by Dr. Sushila, and I welcome her for her presentation on mental health issues. Dr. Sushila, you are there?
You have to unmute yourself.
Yeah, please unmute yourself. I would like to ask Shriman if there is a general link which I can post in my department group so that more people can join. Shriman, is there a general link or everybody has to go through that pre-registration?
No, ma'am, everyone has to do the registration, then only they can
But
join.
that's fine. But is there a general link which I can post?
No, madam, nothing like.
Okay. Go ahead, please.
Yeah, 1 second, doctor. Can you see my screen actually?
Yes, ma'am.
1 second. So good evening, Dr. Sureka, Dr. Pratibha, Dr. Neema Madam, and faculty of Jawaharlal Nehru Institute, and also the members of DSOG. So thank you, Dr. Sureka, for the opportunity. So we have seen what is violence against the antenatal women and the pregnant women, and also how do we need to approach them. So I'm going to discuss about the mental health issues that women suffer when they are because of the violence during their pregnancy. So this is a case report wherein Mrs. R, 26-year-old, and she's 28-weeker, and with regular antenatal checkups, no comorbidities, and her vitals are stable, abdominal examination and vaginal examination are unremarkable, but she seems to be very depressed. So on inquiry, she was found to be beaten by her husband. So in this case, do we have to gather the information from the patient, and whether we need to inform the police? Do we need to counsel the patient? What are the problems the patient can come across? Do we need to counsel the family? Do we have to prescribe any medicines? And then do we have to think about the aftermath of intimate partner violence? So these are the things we need to think about, and you can as well put your comments in the chat box. And we are the first line healthcare providers, but at the same time, the psychologists need to counsel them, and the psychiatrists need to address them regarding the medication too. So why is mental support very much needed in these patients? It is because they go through the post-traumatic stress disorders, and there is depressed mood problems like depression, suicide, substance abuse, sexual disorders, and phobias may be there because of the stress GI symptoms. dissociation symptoms, and they may also withdraw from the society. And this is mainly because of the life-threatening injuries that they have pursued because of the violence. So do we have to intervene? Definitely we do have to intervene. We do have to ask about how frequently they are being abused and what is the severity of it. Like, is it for a short time or a long time? And then we need to think about their safety too, because they may have the suicidal and then suicidal tendencies. So we have to assess the pregnant women regarding their actually their status. That is, we need to think about their we have to evaluate their psychological screening. Suicide and danger assessment has to be done, and also assess the domestic homicide risk. That is there any threat to her life also has to be assessed by us. So what are the danger signs? If it is the violence has been like very frequent, it becomes a danger sign. Is there any like bad injury in her? It indicates it is a danger sign. Is there any alcohol misuse? Is there any threatening to kill her or any sexual violence? And is there any suicidal tendency? And then is there any big injury because of a weapon used for threatening her? Or is there any morbid jealousy in her partner? So all these come under the danger signs. And when do we need to hospitalize her? So whenever there is a severe medical injury, when she has a suicidal tendency, or if there is a problem of homicide also, and dissociative or psychotic symptoms are there, the patient is unstable, and then there is an affective dysregulation or self-destructive behavior, or serious, mainly it is because of the serious threat to the patient life. That is the main issue where we need to hospitalize her. So each patient is individually treated, that is, each patient is different. And we need to have a multidisciplinary team to treat her. And the milieu therapy is, we have to move her away from the bad atmosphere, give her the mood stabilization, medical evaluation and treatment has to be done, and psychosocial support is a must. And need for rape kit, photo documentations, and reporting to the legal aid, all these have to be taken care of. So like in 2014, the NIMHANS has started the trauma recovery clinic, and this clinic can be started in any hospital or a multidisciplinary center. This mainly enhances the self-esteem, and it improves the social support to the woman, and also it prevents traumatization. And as well, it gives the classes to the psychologists and counselors how to talk to the victim. So this is one of the important things that should the trauma centers, that is trauma recovery clinics, have to be established all over India. And we can help the women who are like real victims. And how do we give the social, psychosocial help to them? And then to whom we should give? That is the helplessness, when they have the feeling of helplessness, and when they are real in a feeling of guilt, shame, isolation. In all these cases, we have to support the patient, and these are the impacts because of the violence. And then because of the violence, they may also have like a physical separation from the family, and they may also be not able to cope up with their daily routine activities. So the role of the psychologist is also important, because the psychologists are the first one who help them in counseling. So they play the main role in the treatment of it. And the aspects they cover is like cognitive behavior therapy, brief trauma focused cognitive behavior therapy, and all these psychosocial therapies, they help in recovery of the victim in acute cases. So skill training in effective and interpersonal regulation is very important. That is psychoeducation about the impact of trauma on emotions and relationships. And emotion regulation skills can be developed. Effective expression of negative emotions, that is how she feels, we need to ask her. And interpersonal skill related to appropriate assertiveness, that is how do we develop their skills, is also very important. And development of flexibility in regard to the interpersonal expectations, actions, and reactions. So how far she has to feel bad for a bad thing, is regarding the development of flexibility. And treatment also includes the recognition of achievements during the treatment and exercise in self-compassion. So this is all is needed to help the victim, how what are all the problems and how she has to come out of that problem is important. That is the skill training. And interpersonal psychotherapy is important mainly in cases where the victim is in a withdrawal mood from the relationships and individuals. And this is a non-exposure based treatment that helps to come out from the post-traumatic stress disorder. And other psychotherapies include cognitive processing therapies, eye movement desensitization. All these are done by the psychiatrist and psychotherapist. And psychological therapy has to be taken care of. And this is like even the WHO Mental Health Gap Action Program has given guidelines saying that the healthcare professionals with good understanding of violence against women have to take care of this woman. And CBT and EMDR, all these things that are the psychiatrists, psychologists will take care of these women regarding the post-traumatic stress disorders. And even when they go to a psychiatrist, take the treatment, the woman comes back asking whether she can take the medication during pregnancy. After 8 weeks, the medications can be taken as per the prescription of the psychiatrist. And we also need to support them. We also need to counsel the women. And men group treatment therapy is one of the important things. We should encourage men also to come for the counseling, and then they are responsible for the violent behavior, and they need to change their attitudes and develop skills for reacting non-violently rather than violently, and increase the awareness of dynamics involved in the use of violence to the men too. So in conclusion, mental health is a big issue, and we all should know how we have to tackle the mental health issues in a case of antenatal women facing the violence. And we definitely need to address along with the physical health and not only the prescription, we have to talk to them and then give the proper support to them. So requesting you all to complete the post-test and also feedback form. Thank you.
Thank you very much, Dr. Sushila, for that wonderful insights into mental health issues women with violence will be facing. And I would also like to welcome Dr. Amani Rafat, who is the mini grant committee chair from Women and Health Together for the Future. Welcome, Amani. There was some problem with the registration that she couldn't join. She joined a little bit late. So we would be going to the discussions after one more, talk, Dr. Amani. And I would like to invite Dr. Pratibha to talk about the challenging situations in violence against women and self-care of the provider. That's also a very important topic, and I would invite Dr. Pratibha for the same. And I would request the participants to put their question in the chat box, please.
Hello, can you see my slides?
Yes, Pratibha, slides are seen and you're heard well.
So now I will be talking about the challenging situations in vow and self-care. So why we are dealing, because normally such females who have such type of suicidal survivors, they feel so much hopeless, and they have that suicidal tendencies, and they sometimes think that they want to end their life. So these are the challenging situations where we have to deal, how we are going to deal such situations. So we'll be talking about that. Now, this is one case scenario where you are a gynecologist and one of your patients in your clinic tells you she is being threatened by her mother-in-law, who is constantly pressurizing her that she must divorce her husband because she is unable to have children. She feels hopeless and wants to give up. So what do you think? Should you do nothing, or you should be doing something? So I will request you all to put your answer in the chat box. What do you think in such situations you should do? There are few ideas which I can give you, like be able to recognize the signs of depression and suicidal risk. Do not be afraid to ask, are you having thoughts of suicide? Because she is telling that I just want to end my life. So you must always give a direct question, ask her directly that, are you having the thought of suicide? And if the answer is yes, then you must take it seriously. Do not leave the suicidal survivor alone if there is any immediate danger. Always consult a supervisor about how to refer or manage such suicidal survivor. Never take decision by your own, because if you want your own, because that is not in favor of your own safety and also for the well-being of that survivor. Provide a referral to the gender-based violence expert agency, OSC, for additional help if possible. Now, Obgyn should not ask survivor about suicidal thoughts or attempts. It could encourage suicidal attempts. So this is the question I want to ask you, that you should not be asking the survivor about the suicidal thoughts or attempts. Is it true or false? I want you to answer about this and put it in the chat box. What here they are saying that is false, because asking about suicide attempts or thoughts does not increase the suicide attempts. On the contrary, talking about suicide often reduces the woman's anxiety about suicidal thoughts and helps her feel and understood. Now, if the survivor tells you that there is abuser has threatened to harm them, what should you do? Put your answer in the chat box. There are a few ideas which I can give you, like you can ask concrete question about safety risk, but only when you are talking to her in privacy. Second, ask if survivor has any safety plans. Ask if she wants to go away from there or she wants to run away from there. So that you must ask. Then discuss about the potential strategies. Provide a referral to the gender-based violence expert agency or one-step crisis center for additional help if possible. Then one of the most helpful technique for helping a survivor to get out of her over-emotionally state is to ask them close-ended questions that require them to think. So that will shift them from an emotional state to the cognitive state. Should require short answer. Do not return to open-ended question unless the survivor feels comfortable and she has some degree of emotional control. So what type of the close-ended questions you might ask, like how many kids you have, are they in the school right now, what are their age now? So this way you can ask her, because these are the questions which she can answer. So you must be asking such type of questions, that is close-ended questions. Now, another challenging issue is when you are dealing with a survivor who may be mentally ill. And in such cases, you have to be very, very careful. First and foremost, you must clearly tell that what is your role, who are you, because that she must understand you are her well-wisher. So that way you must clarify your state, that what is your role and who are you. Be empathetic, non-threatening and sincere in your intention to help. Give honest, factual answers whenever necessary. And if you don't know, you say no. Do not belittle concern which the survivors raises. Do not give advice as to the handling of these psychological problems. Attempt to be supportive in comments and gestures. And do not assume mentally ill people should know better, or on the other hand, they need to be told what to do. So be careful about making any assumption. Know how to activate emergency mental health care backup, because that is also, sometimes you require that also. Now, additional challenging issue is mediation. Now, what is this mediation? What do you think about it? Can it be a part of this process? So remember, mediation is not recommended as a response to gender-based violence. Health workers are a part of survivor-centered referral mechanism. The mediation process itself maintains and contributes to the abuser's ongoing power over a survivor. The process of mediation presumes that both parties can speak freely and safely. That is not the case. Mediation rarely results in an end to abuser's violence and can actually lead to an violence. It is unlikely that the survivor's right will be respected in such cases. So you have to think about that, because this is also an additional challenge which you can get where you have to be a mediator. Now, what is core safety precautions while dealing with challenging issues or cases? So you must not deal such type of incidences alone. Multiple people can handle difficulties better than single person. A service provider should never feel like that she or he can work alone with a survivor. Another very important thing, that the service provider should not work with both the perpetrator and the survivor, or even neither separately or in the interview. Then keep the office door open of leaving the office or home if you feel unsafe. Then you must establish certain codes with your co-workers so that whenever you are in some situations which is unsafe, you can use that code words. Then establish a relationship with the local police or security, because they should know that you are dealing such cases, and if in case of emergency or in need, you can call them, and they also know that you will be needing help. Use buddy system at work and to and from work, and if doing home visits. Use supervision to address security concern, because a group of a person can address security more effectively than individual. So it should be always no single-handedly it should be handled. It should be with multiple or with the core team, because that will give you a safety precaution. Self-care for the provider, it is critical for you. Do you know what is vicarious trauma? Anybody if knows about this vicarious trauma, put your comments in the chat box, and if yes or no, you can write that. As a service provider, you should be aware of it for self-care. This is mainly for yourself, for your self-care. So what is vicarious trauma? It is a change in the service provider's inner experience as a result of emotional engagement with survivors of the trauma and hearing their stories. It changes that occur in the service provider's physical, emotional, and the behavioral state as a result of constant exposure to the traumatic stories or events. You keep on listening to such stories, and you start believing in that, and you start living in that stories, and that is known as vicarious trauma. So what are the causes of this vicarious trauma? This is mainly constant exposure to such stories or trauma, desire to help or change the survivor's situation. And when you feel that you want to really help her and you are not able to do anything, then you start having this type of feeling. You start feeling powerless when a service provider does not see positive change in the survivor's situation. Overlay identifying with survivors, then thinking that the service provider has the power to change the survivor's situation. Sometimes the situation is such where you cannot help her to greater extent. So that is that limit you must understand, till what limit you can help that person. How can you prevent and manage this vicarious trauma? These are ABCS, that is awareness. Being attuned to one's need, limits, emotions, and resources, practice self-acceptance. You must practice this. Balance, should be maintained between your activities, especially your work, your house, and the rest. Then connection, like maintaining supportive relationship, communication of connection, and break the silence of unacknowledged pain. These connection helps to prevent isolation and increase validation and hope. So self-care for the health provider can be by creating boundaries in the workplace. You should know what is your boundaries, till what extent you can work, establish support with the work environment, Seek assistance from outside agencies. You cannot do everything. So you have to seek help from others. Create your own self-care plans and follow them through. Now, this is one quiz where you have to, in my last talk, I have told about empathy and sympathy. So pick up which statement describes sympathy and which statement describes empathy. So statement 1 is a personal emotional identification with a survivor's experience, and that implies the service provider feels sorry for the survivor. It is an emotional statement, leaves the service provider vulnerable to over-involvement and can take power away from the survivor. And the second statement is an intellectual, personal understanding and realistic professional display. It involves compassion and objectivity and leaves room for empowerment of the survivors. So put your comments in the chat box. We need some comments in the chat box. Whether the statement 1 is sympathy or empathy, or statement 2 is sympathy or empathy, please write your comments in the chat box. Now, how do you take care of yourself? Put your comment in the chat box. Some relaxation and self-care techniques, what you use. We must also know what you think, how you can take care of yourself in such situations. So that please put it in the chat box. Thank you so much. Again, I'll remind you that you have to complete your post-test and feedback form so that certificate of participation can be awarded to you. Thank you so much.
Thank you, Dr. Pratibha. That was really a complex issue, challenging situations which we can really face when we are dealing with the women facing violence, and specifically the emotional connect we feel, and we may get traumatized when dealing with women. So that again, sometimes we see these women in our dreams also. If we get really upset and affected, so we do have to have our own system of self-care. And I am sure that all of you agree that it's really emotionally disturbing also. So we have Dr. Amani here with you, and let us break for a few minutes for discussion before we go ahead with our next topic. Dr. Amani, your comments, please, about this, self-care and, situation of challenges we face when we deal with these women. You're muted, Dr. Amani.
Yeah. No, I muted myself now. Yes.
Yeah.
Hello, everyone. I enjoyed hearing all these experiences with dealing from the clinical aspects for women and survivors of women violence against women. I have a long experience in conducting research on other aspects, not only clinical, because women, it affects their ability to work, to raise their children, and they start to be perpetrators themselves, because the cycle of violence, when women become victims, they impose violence to their children because they are the weaker. So that affects them. So the domestic violence circle is still in the family. So if we want to deal with the situation, we have to look for the family as a whole, not only the men or the perpetrators as men. Other aspect is that the violence against women affects their utilization of all kinds of health services, including reproductive and sexual health services. I had a lot of research about that, and I found that the women who are exposed to violence are less to use family planning programs or go for antenatal care or use skilled birth attendants because they are afraid and they are shameful. And on the other hand, you discussed how the physician or the health provider should identify the victims, because it is usually, not in all cultures, it is identified by medical or health professional institution or providers. In a country like mine, Egypt, they consider it sometimes that it is a private issue, not a medical issue. It is not the concern of the doctor or the health provider. So we are trying to raise that awareness among them, among the new generation of doctors and nurses, that they have to look for that, because our culture still look that this is a private, this is a household issue. We cannot report about that. In spite that, we have a hotline for violence against women from the Women Council, High Supreme Council of Women. Rarely it is used or identified by women in our culture. So we still need work with them. I enjoyed that discussion about the mental, and I found from my research also that the most stressful situation is from emotional abuse, because it is less appearing. Well, physical will appear, okay, contusions, injuries, and she will go to the hospital, even if she said, I had fallen or something too, because of she's shameful of the situation. But emotional violence, belittling and threatening, and letting her feel that she's incompetent or she's not needed in the family, that affects her very much. And I found in one of my studies that women who are exposed to emotional violence more to have extramarital relationship, and that introduce them to unsafe sexual practices, because they look for emotion, they look for support, they want to have to be loved, to be cherished, and they don't find that in home. So they look, and that exposes them to risky sexual behaviors. So this is another issue that sometimes are overlooked, the emotional abuse, not the physical or sexual.
Yeah.
Of course, one of the questions here about sexual among marriage. Yeah. So yeah. Okay. Thank you.
Thank you. Yeah. We'll go ahead with our presentations, and now we have Dr. Sushila will be having two back-to-back presentations, one on the support system and another on how to approach a woman with sexual violence. So Dr. Sushila, please.
So I would deal with the support systems and resources for survivors. And what Dr. M.A. said is really true, actually. A good message for all of us that we should definitely, as healthcare providers, to take care of the victims. And coming to the our presentations, and I sincerely thank Dr. Anita, Jyoti, Rohan, Ramni Devi, and Dr. Kiranmai Ajay for all the presentations. They were like really so important aspect has been brought out by Dr. Shantakumari, and then all these have been prepared by the doctors. So we have gone through the mental issues, all the other parts of it. So what is the overall view of the sections? We shall see in the next few slides. What are the protective laws and acts? What are the helplines that we have in India? What is the one-stop crisis centers available? And then what is the rehabilitation of the survivors, and how do we link up? These are the issues we are going to talk in the next few minutes. So the protection of the woman has been brought out by an act which is called the Domestic Violence Act 2005. Prior to that, we had a Indian Penal Code 498A, which was helpful for women, but there was no emergency relief available then. And remedies available were linked only to the matrimonial proceedings, that is not covering the all the women. And the court proceedings were always like protracted, and the victim has to be with the abuser and then at his mercy. And the relationships outside the marriage were not considered. So the 2005 Act has been brought in, and it is a civil law. And the main difference is that it covers the woman within the marriage and outside the marriage, that is the female partner also. And there is no punishment or arrest unless the husband violates the court order. And another difference is that it can be booked only against the male members of the family. So whom can the woman complain to? That is, she can complain against the male abuser. That is, if she is the wife, she can complain the family, total family. That is, the male abuser can be complained of. And also a woman who is in relationship similar to the marriage with a man. And a transgender male to the female could bring an action against a transgender female to a male. And a woman who is in live-in relationship with an unmarried man, but not with a man who is married, if she knew or ought to have known that he was married, that the important thing is she doesn't know that he's married, but she's in live-in relationship with that man. And anyone can file petition with the survivor's consent. So this is all like about who can be complained of. And to whom she can complain is a protection officer, service providing center, medical officer in charge at a police station, or to a magistrate. So where she can complain? So 3 options are there. She can complain where she is permanently or temporarily residing, or the husband is temporarily or permanently residing, or where the action has taken place. And what are the types of the orders? It is a protection order, wherein the violence has to be stopped immediately. There should be an emergency relief to her. And the residence has to be like, she can share the residence with the perpetrator, or she can ask for a separate housing, or she can have a custody order, and she can also go for a compensation order. And the violation of the above order of the offense, and a magistrate may charge offense. That is, it becomes a non-bailable warrant if the husband doesn't provide all these things. Then it becomes a non-bailable warrant. And within 3 days of the application, the hearing has to start, and it has to be disposed within 60 days. And the file of the detailed investigation report has to be started, and the complaint has to be given a shelter, and they have to be given a free legal service. It cannot be charge legal services, but it has to be a free legal service, and the counseling has to be provided to the victim. And domestic legal remedies in India we have so many acts, articles to say to protect the woman. One is that male and female are equal according to the Article 14. There is a Dowry Prohibition Act, and the National Commission has been set up, and there are so many posts to help the woman. And also the law, that is IPC, has been modified. Like in 1993 it was there, but now it is 2005, where it is called the Protection of the Woman from Domestic Violence Act. And the concept of one-stop crisis center has been put up, and this is mainly to cater the immediate medical, legal, psychological needs of the women who are the survivors of the physical and mental abuse, with an assurance that their consent and confidentiality will be respected and protected. Like respectful abortion care, where we maintain the privacy, here also we need to maintain the privacy, and also we need to take the consent. And Bharosa centers and the SHE team officers are available to help the victims, and also the psychologists, the police, the counselors, etc., and the medical help, and all these are being provided. And helpline 100 can be approached, and then they will direct to the Bharosa centers in case of the violence. And the next 3 slides, we have the numbers where we can call up. That is the All India Women Helpline, Women Distress Cell, that is 10991. Like in Child Helpline, it is 1098, it is 1091. And other numbers also we are being provided, like Women Domestic Abuse Helpline, Delhi Commission, and Outer Delhi local bodies, National Commission for Women. All these are being provided, and we should also give to our women. And in various states also, there are helplines like Bhumika Women Collectives and Women Protection Cells. And all these numbers we can provide to the women who are the victims. So Sureka, can I just go to the next?
Yeah, please go ahead to the next one. Because once we finish your 2 presentation, then we can have a small discussion.
One second. I think there's some problem.
You have to close your slides first.
Yeah, I'll do that, madam.
Yeah. You have to close this.
Not able to. Yeah. So now I'm going to discuss about the sexual violence and how to approach a woman facing the sexual violence. And thanks to Dr. Jyoti, Dr. Kiranmay, and Mr. Ajay for the presentation. And how is sexual violence defined? So it is an sexual act or an attempt to obtain a sexual act or unwanted sexual comments, or it can be trafficking, or it can be a comment directed against a person's sexuality using coercion by anyone regardless of their relationship to the victim in any setting, including at home and work. So basically it is a sexual act or an attempt is a sexual violence. So the rape is a term which we commonly use. It is a violent one and it is a forced one, or as WHO describes it, it can be anything like penetration forcefully, either in the vulva or anus, or using vulva or anus using any object, or it can be a body part like penis. So it need not be like semen should be present in the vagina to say it is rape, but it can be an attempt to. So many times we come across people who have been sexually assaulted, and victims usually know the assaulters, and the victims are never at fault, and we cannot blame the victim for the sexual assault. And rape is the least reported and convicted violent crime in not only in India but in the world. And sexual violence is preventable and help is available. So because sexual violence is preventable, that is where the Dheera school program, we are like trying to educate all the school children, and definitely help is available. So we have all the helplines, and then you can share the numbers with the women. So there are different circumstances as settings, like where we can say it is a rape within the marriage or a dating relationship. It can be with a stranger. And then it is like in the form of a sexual abuse for children, or in case of mentally or physically disabled people, or it can be in the armed conflict, like we have seen like in newspapers, in the media, that is in Ukraine and all. And then it can be a sexual harassment in the workplaces where they demand sex in return of favors. So all these come under the sexual violence. And even in case of forced abortion, it comes under sexual violence. And denial to use contraceptive methods, wherein like it is requested by the women to prevent the sexual transmitted diseases, or in cases of forced prostitution, trafficking of people, in case of forced marriages or cohabitation, including the child marriages, and in cases where it is like female genital mutilation. This is commonly seen in some of the sex, some of the people where the female genital mutilation is done in India and also in Africans mainly. And in case it is like inspection for virginity also comes under sexual violence. So marriage is often considered to be one of the things like legitimate one, a form of sexual violence. And many a times the marriages, child marriages takes place, and the children, they really do not know what is sex and what is happening and it is not done with their consent. And the consequences of the sexual violence, as we all know, it is pregnancy, gynecological complications, sexually transmitted diseases, mental health issues, suicidal behaviors, and social ostracization. And the fatal outcomes are the suicide, homicide, and sexually transmitted diseases like AIDS and related diseases. And the non-fatal outcomes are like unwanted pregnancy, infertility, sexual dysfunctions, chronic pelvic pain. It may be like infertility too, and infections, obesity, anorexia. And due to the stress, it can be gastrointestinal disorders, frequent headaches, fatigue, nausea. And coming to the psychological consequences like rape, trauma syndrome, post-traumatic stress disorder, phobias, shock, fear, confusion, anxiety, guilt, nutritional disorders like eating disorders and anorexia. And sexual assault is one of the most invasive and intimate forms of violence. And a trauma-informed care approach should be utilized by the healthcare providers. Neurological, biological, and the psychological understanding has to be there to help the woman. And when a patient presents and reports a sexual assault, triage has to be done. And triage is always a medical emergency. And the immediate needs a survivor needs is medical, psychiatric evaluation and stabilization. And community advocacy is also required. And mandatory reporting has to be done to the state authorities. And conducting the sexual assault forensic examination, that what we call as SAFE, has to take place. And collaboration with the law enforcement and prophylactic medication for STIs and STDs. And if needed, emergency contraception has to be given, and we become the experts, medical expert witnesses in all these cases. And we all should know how to provide safety to the women, and we have to gain trust from the women, and the women have their choices. We work with the collaboration, that is with the consent of the women, and we need to empower them. And regarding the safety, we have to be compassionate, and we have to be very warm to the patient. So we need to knock at the door, ask their permission, and meet with the parents before they disrobe. And partially only we need to disrobe, and we need to show them the washrooms, familiarize with them. And the most important thing is the comfort level, and we need to show them the respect too. And how do we gain trust? It is like talking to them in a sympathetic way and explain her all the procedures, tell the person what to expect and how long it takes for the examination, and ask the person what he or she wants. And it is the choice of the woman basically, and ask if you can touch each time that we need to examine the different parts, and ask before you invite a staff into the room, and ask if you can close the door and allow the person to decide whether she wants to sit in the room or in which position she wants to get the examination done, and explain the rationale of each procedure, why we are doing the examination. Is it going to hurt, or like how gently we are going to do the examination has to be explained. And then we obtain the consent for each part of the examination what we perform. And then ask what are the top worries or concerns, and then we need to address them, share all the information, encourage the person to make decision about the treatment. So though we give options, it is her decision. And the most important thing is the empowerment. So ask what happened to her, and it is not like what is the wrong thing. And then we have to be very careful when we use words, that is, never ask why, and take time with the person so he or she feels genuinely heard. So we have to take some time to talk, to create a good atmosphere while we are talking to them. and ask if the person has preferences related to or she has any difficulty with a particular procedure, and ask the person what they want to know before we begin the procedure, and make them relaxed. And then like we have to pay the attention to the body cues, and many survivors have been like conditioned to be a passive and defer the authority, and so may not disclose the distress even during the procedure. Even they have pain also, they may not disclose. So always we have to create a good atmosphere before we examine, and then we should gain the trust from the patient, and always remember to give the choices to them, and we need to take the consent. So the elements of the sexual history are the medical history. Recent consensual sexual activity has to be asked. Assault related medical history has to be taken, and all the details about the sexual assault, nature of the assault, and post assault activities. And we have to also inquire about the information of the suspect. So this completes the third part of my presentation. Thank you so much. Do complete the post test and also feedback. Thank you, Dr. Surekha, Dr. Pratibha ma'am, for the opportunity.
Dr. Sushila, thank you. That was really a complex issue, and a lot of information we are providing, to our participants. And we do know that clinical care of violence victims is really a very complex, very comprehensive sort of care we have to provide. Not only the examination, but the psychological issues. So many things are there, and we do know that medical legal aspects are also so important, so that the perpetrator can be brought to justice. And we really need to take care of how we are examining, how we are documenting, because we are going to be the ones who are going to be giving the evidence in the court. That also we have to remember. The Indian law specifies that the one who is examining and collecting the evidence will have to, go into the court and give the supportive evidence also. So we really have to be
medical expert. Yeah, we become the medical expert, Dr. Surekha. And other thing is, we have not read any part of this in our medical school. This is so very important for us, like in our practice too, and also for being a medical expert. So we see many a times that the medical legal aspects, when they come, like poisoning cases, trauma cases, all the other doctors, even the private practitioners, they go to the court and then help them. But when it comes to a case of a rape or a sexual assault, we are so afraid because we do not know anything about all these things. So I think next part, what you deal is really important. Like, how do we become the experts? How do we help the patient to get the justice, actually? Thank you so much.
Just a question to Dr. Amani. We are having such a lot of, we a support system from the court of law. There are the laws to protect women. There are one-step crisis centers. The judiciary will always be in a favorable mode. The court has to finish the proceedings within 2 months. So any such thing in Egypt? Just briefly, would like to know.
Yes, there are. And there is laws, and they are changing to support women now.
Amani, we are having a lot of echo from you. Echo is there. Are you having 2 devices?
No.
Okay, please go ahead. I don't know.
Better now? Do you hear me better now?
Yeah, better.
Okay, directly from the computer. Well, yes, we have in Egypt laws supporting women, and they are changing laws, and they are incriminating sexual harassment and rape. And of course, female genital mutilation is banned by the law, and any doctor do it is expelled from the syndicate. So he's barred or she's barred. Usually he is a male. Okay. So we have that similar, and we have, however, it is the family usually in rape cases do not go by themselves because it is cultural and very sensitive. But sometimes they start to talk, especially among the educated. the sexually harassed, those who are exposed to among men or women, because we have also sexual harassment for men. Okay, and there was a very famous case in the court. A dentist was harassing his patients, the male patients. Okay, so this happens, and but it is not regular because the culture do not accept that clearly.
That's what I thought. That's why this question, in India, we have a lot of support system, but may not be so in different regions of the world, in different countries. The laws may not be so favorable. So that was why I asked this question to you. And let me tell you, Dr. Amani and everybody who are the participants here, the next topic is very technical, but it is important, how to examine, how to document. There are specific, ways how you will document. The government of India has the kit, what also available, which you need to be very careful how to use, and the evidences. And as doctors, as even the private practitioner or the public health, both of them, it is imperative that we learn this, because it may not be taught in our own curriculum. So we really need to pay attention. And I have been from a medical college where I have seen number of such cases, and I have learned from my seniors how to fill up the form, how to actually gather the evidence, how to seal the evidence, So first-hand information I do have, and I would request that this is really a little bit technical, and some of you may find it cumbersome, but I suggest that it is a really important topic, and I would go ahead and talk about this topic about examination of the survivor and the medico-legal issues, which a little lengthy topic. I'll be try to cover in brief, and then keep some time for any questions. So again, Dr. Vindhya and Kiranmai, Dr. Ajay would like to give credits for this. And the role of gynecologist is very important, because the evidence of the crime will help the judges to understand the physical and mental condition of the survivor, and the reports are able to corroborate the story of the survivor and enhance the credibility of what she's saying. She's communicating with you. The counseling, the treatment part, all these are important. So these the medical examination will be, you'll have to record the history. Informed consent is very important. Injury documentation, evidence collection, which I'll be talking about. So there are almost 25 different things which you need to really fill in the form and document. There are some general instruction, consent, identification, medical surgical history, what is the type of violence, physical examination, injury documentation, external genitalia, systemic examination, sample collections, and providing the medical opinion, then the treatment, and of course the final opinion. So almost 25 different elements are there in the form we will be filling. As you can see here, these are a lot of technical details regarding the patient, the name, the address, age, sex, date and time of arrival, commencement of the examination, who brought the patient. If the patient has been brought, or the survivor has been brought by from a police station, the MLC number of the police also has to be documented. What state of consciousness she is, or any physical disability is there. Then if she's not able to communicate, if any interpreter is required or special educator was there, then that too has to be documented. And of course, the informed consent, if she refuses the consent, then that too has to be documented. And the medical examination, medico-legal examination, sample. So this is part of the consent which is available. I'm not going to go through the details, but yes, the consent documentation is very, very important. Marks of identification. This is, I think, a really important point we need to. These marks could be any scar or mole, and you need to, if she's not able to sign, then and also the left thumb impression. Even if she's able to sign, you have to take the left hand. These are the relevant medical and surgical history. We also have to take the history, as I have mentioned, onset of menarche, menstrual history, last menstrual whether she was menstruating at the time of incident, at the time of examination, was she pregnant? If yes, what are the duration of the pregnancy? Contraception use? If yes, what are the methods? What is the vaccination status? Has she been vaccinated against tetanus, hepatitis B? All these need to be documented. Then, of course, the sexual violence has to be inquired, the incident, the time, the location, estimated duration. Sometimes the patient may come to you after a duration of even 2 to 6 months. So that too has to be documented. Was the episode one or multiple? What was the number of assailants, sex of assailants, approximate age of assailants, if any known relationship of the assailant to the survivor. The incident need to be described in the words of the narrator. That has to be also documented. And if you need an extra page, you need to have that too. Type of physical violence, as I have mentioned on the page, what is the type, whether it was by hand, fist, any object was used, biting, pinching. So you need to describe. Then the emotional abuse, whether there was restraining, threatening, insulting words, verbal threats, luring with sweets, chocolates, drinks. You need to really be detailed about your history. Any history of alcohol, intoxication, whether she was sleeping or unconscious at the time of incident. If the survivor has left any marks of injury on the assailant, then that detail too you need to be. Then regarding the sexual violence, whether the penetration, what sort of penetration, by penis or fingers or object, and this is the detailed form which has to be filled into. Oral sex, forced masturbation, exhibitionism, ejaculation, whether it was outside the body orifice. This is important because we need to collect the semen. If the ejaculation is on the other body parts, that will provide us some the sample of the semen, which will be you will be able to identify the perpetrator later on. Condom use, if yes, the status of the condom, and other object. That also post-incident details, whether she has changed clothes, changed the garments, washed the clothes, bathed, doused, passed urine, passed stool, the rinsing of the mouth, brushing of the mouth. All these are important things. Any bleeding, vaginal, anal, or oral, painful urination, any other symptom, painful defecation, any fissures, pains in the genitalia, all that need to be documented. General physical examination, height, weight, general build, gait, pulse rate, all the vitals, any disability, deformity, all these need to. Injuries, very, very important. What marks she has on the body, bruises, nail aberrations, teeth bites, cuts, lacerations, fractures. We need to be really detailed, what injury, where it is, what is the size, shape, color, are there signs of healing? Is it a simple injury? Is it a grievous injury? What are the dimensions and the position where it is? So this is really, really important, to make your opinion, final opinion. External genitalia, about labia, majora, minora, urethral meatus, fourchette, perineum, hymen, everything. Please examine well, document the injury if it is there, and what is the situation of the external genitalia. Systemic examination is also important. If there has been any other physical abuse, you may find that the patient is having intraperitoneal bleeding, or you should not miss anything. You may concentrate on the genitalia, and you may miss something, some systemic disorder, or some life-threatening event. So that would need to be documented. Then, of course, collecting the samples, It's important, every contact leaves a trace. Remember that it's important to establish the link between the victim and the scene and the assailant also. So you have to always maintain the chain of evidence, identify the specimen, label the specimen, and record how the specimen has to be disposed. So blood sample for HIV, VDRL, HBsAg, HCV, urine pregnancy test to find out if she's pregnant, ultrasound if the pregnancy is there, or to find out any internal injury, X-ray if you find any injury, and of course, clothing has to be collected to be packed in a separate paper bag after air. So very important that the clothing is also an evidence. And all these samples, swabs from the stains on the body, scalp hair, head hair, it has to be combed, and some sample has to be sent, nail scrapings, oral swab, blood grouping for typing, blood for DNA analysis, any other tampon, sanitary napkin, or condom, or any object you need to collect. And if you're not collecting, then reasons for not collecting, important. Genital and anal evidence sample needs to be packed, sealed, labeled separately, and has to be placed in a bag. So matted pubic hair, cutting of the pubic hair, mention if it is shaved, 2 vulval swabs, 1 for semen and DNA, and 2 vaginal swabs and 2 anal swabs, again for semen and DNA, vaginal smear for semen examination, urethral swabs. All these samples need to be preserved and directly handed over to the police. And of course, you need to make a median. And this is the format: examine the survivor, age, reporting type, and you need to document my findings are as follows. Samples have been collected, and clinical findings, additional observations, and what treatment you have prescribed. If you have prescribed, yes, no, and the comments. So STI prevention, emergency contraception, wound treatment, tetanus prophylaxis, hepatitis B vaccination, post-exposure prophylaxis for HIV, and counseling, and date and time of completion of examination, signature of the examining doctor, name, place your seal also. Report has to be, number of sheets, how many number of sheets, what are the number of envelopes, all this has to be there in the format which has been prescribed. And final opinion can be of various types. This I'm just going to read, it's a very technical, what your opinion can be. You can see there is an evidence of recent sexual intercourse when there is an injury to the genitalia and other parts of the body and motile sperms are found in the vagina. Remote sexual intercourse if healed injuries are there, but there are no motile spermatozoa. Recent penetration if local recent injury is found with no spermatozoa. And you can say history of remote penetration if healed, partially healed injuries on the genitalia but no spermatozoa. Recent evidence of sexual assault if recent injuries are there on the face, cheek, neck, breast, nipples, but not on the genitalia. And then evidence of remote sexual assault if partially healed injuries or bite marks are there, but nothing is seen on the genitalia. And sometimes there is no evidence of vaginal penetration, but possibility cannot be ruled out. So all this kind of opinion you can give. Then there could be an evidence of recent oral or anal intercourse, evidence of remote oral or anal intercourse, evidence of recent or remote anal or oral penetration, or there could be no evidence of either oral anal penetration, but possibility cannot be ruled out. These are the ways you should be writing your opinion, and what are the findings which support your opinion, your lab findings, your clinical examination findings, you should write in detail. So this format is actually available on the internet also, which you can download and you can use for reporting. Signature of the doctor and examining name of the doctor, the place, the seal, and this copy of the entire medical report has to be given to the survivor free of cost actually. This is a summary: consent for vaginal examination, injury documentation, sample collection, and final opinion. This is in fact, a summary of what should be all be the part of the exam: the consent, the first aid, history, examination, the age estimation, physical, dental, radiological examination, evidence collection, treatment, and discharge, follow-up, and handing over the evidence to the police. So that is all. And of course, these are the annexures already available, the sexual assault forensic examination kit available and on the internet. I acknowledge, of course, Dr. Shanta Kumari for all these, the whole module which has been prepared under her guidance, and Dr. Kiran Mai also for, and all the people who have done the module. So now the forum is open for any discussions. I know that it is a really technical presentation which I have made, but I think it's really important that all of us learn it. Being gynecologists who are the caretakers or the health providers for these survivors, it's important that we really must know these things. So any comments from anybody? All the participants are welcome. Pramita, you want to say something? You have been there throughout, and I would like to know your opinion of the whole module. Then we have Shikha. Shikha is there?
Yes, ma'am.
Yeah. So how do you find and what do you think about it?
Yes, ma'am. It's in residency also, we have seen patients, but we don't know the exact way to approach this kind of patients or victims. So we mostly rely on the paperwork they have given us, the police officers give us. But actually, it's very helpful to us also that we gain so much knowledge after this presentation.
Yeah, Shikha, thank you so much. And we have Pramita here. I'm not finding her now. Dr. Pramita is here. Then we would like to know the opinion, and any opinion, last opinion from Pratibha. You want to say something, Pratibha? Please unmute yourself.
Yeah, it was really wonderful, and we are learning. Even we are learning with this. So many things we were not knowing. So that is very important, and this should spread everywhere. That is very important, because many of our patients, many such type of patients we deal. So we should know how to approach such patients and what way we can help them. That is very important. So
yeah, Dr. Sushila.
This is a very good program. Very good program to say. And then each and every obstetrician, I think they should really know about all these things. Otherwise, in future, where the medical legal issues are going to go up, it is really a problem. So this is, and then we should thank all the people who have put up so much hard work in the presentation. So out of our syllabus, out of our curriculum, and then to help each and every woman and also the obstetricians, we should salute them.
Yeah. Amani, last comments from you and before we close the program.
So I personally enjoyed and I learned a lot of information in India. And I hope that the participants learned a lot from this presentation. This is a very interesting presentation. Thank you.
Yeah, thank you so much. And the link has been posted for the post-test and feedback. And unless you do the post-test and feedback, you will not be getting the certificate. So that's important for all the participants to please click on that. The post-test is the same as the pre-test. Only something which you have learned and you're changing your knowledge and change in your knowledge, the knowledge gain. That is what we want to know, and the feedback about the program. So I would like to thank everybody for being there with us, specifically the speakers, Dr. Sushila and Dr. Pratibha, Dr. Mani, who has joined in spite of her busy schedule and shared with us her experiences. All the participants who have been there with us, I thank them and the Devli Savangi OG Society and the Department of Jawaharlal Nehru Medical College and the Women in Health Together for Future. All three, I would like to express my gratitude, and also Shriman, who has been here throughout, and Dr. Shanta Kumari as the Program Director. With that, I take your leave and I wish everybody a very good evening and happy dinner with all your families. Thank you very much.
Thank you, Dr. Surekha. Thank you, Dr. Pratima.
Thank you. Thank you, Dr.
Thank you so much. Yeah. Thank you so much, madam.
Thank you and see
Madam,
you.
actually, the link is in the chat box. I think if they.
I think most of them must have been taking that link.
Yeah, maybe
and I will be posting them in my department group, in the DSOGS group. So
Yes,
I don't think there is a problem.
Last time we
Shriman,
had
is
a
that
problem.
fine? Can we close, Shriman?
Yes, madam. Yes, ma'am. We can leave
Yes.
the meeting.
Yeah. Thank you so much.
Yes, welcome, ma'am.
Okay.
Yeah, thank you.
Bye.
Bye. Bye,
Bye,
everybody.
ma'am.
Bye.
Thank you, Dr. Surekha.
Bye.
Bye-bye.